very good morning, dear ladies and gentlemen. I warmly welcome you all to another important free webinar program organized by the Society for Health Research and Innovation Academy. Let me share a few reminders with you all. The link for joining the session will be available until 9:50 a.m. and access to the session will close promptly at 9:50 a.m. and late attendees will not be admitted beyond this time. As you know, by participating in this program, you can earn 1.5 CPD points. To earn your CPD points and certificate, it is essential to attend the webinar in its entirety because the Shri webinar series strictly adheres to NCCPD guidelines. And I hope you will keep your microphones and videos turned off throughout the session. And you can ask questions via the chat options at any time. And there will be an opportunity to address your queries at the end of the lecture. And after the webinar concludes, stay another few minutes and ensure you fill out the Google form provided in the chat box. To receive your CPD certificates through email, then you will be able to receive your CPD certificate through the email. And this form must be submitted before 11 a.m. today. And we sincerely appreciate your cooperation in ensuring a smooth session for everyone. Without further ado, it's my pleasure to introduce our esteemed guest speaker for today's session, Dr. Pathum Sachinder Herath, Acting Consultant in Sports and Exercise Medicine at Teaching Hospital, Kalathara. Our topic for today is cricket in sports medicine perspective, and it will be highlighting the crucial role of sports medicine in one of the most loved sports in the country, cricket. It will be an interesting session, especially for those who are interested in the fascinating intersection of sports and medicine. Dr. Pathum, having participated in lots of international tournaments as tournament physician and match doctor with thorough experience in sports and exercise medicine within the country and as well as in global platforms, will be the best resource person to discuss this topic. Let us now warmly welcome Dr. Pathum Sachinder Herath to continue with today's informative lecture.
Good morning, everyone. First, I want to thank Society for Health Research and Innovation to give me this opportunity to show you the glimpse of sport medicine. They have informed me that there would be some series of presentations and lectures regarding the sport medicine. So, as the first lecture of that series, I thought that I would start with the cricket. We all know that the cricket is the most popular sport in Sri Lanka, and it has been the joining force since the early 90s. It came with the Englishmen. It has been a sport of elite. Then it gained the popularity among the schools and clubs in the 50s to 70s and 80s, and after the 80s, we have reached the international arena. And early 90s, we are making the name, and after 1996 World Cup, we make the footprint in the history of cricket. We all know, even the period of war, there has been temporary suspension or hold of fighting among the people during the cricket match. So there is something in the cricket, not as medicine perspective of view, but as a society and cultural view, there has been a major impact done by this sport to our society. So cricket is basically a team sport. The players are the keystone of this sport, and apart from that, a cricket team, there have been some supportive staff. It depends at which level these supportive staff are engaging. For example, in school level, they are mostly coaches, but when it go out of the school level into the national level, there are many other coaches, managers, the team managers, player managers, even media managers, and also in some nations they have nutritionists and team physicians, and also physiotherapists, masseurs, video analysts, and also the supportive staff like luggage carriers and drivers also within this team. And when you are in a match as a team physician or even as a match doctor, you engage with others members also. For example, match officials like umpires, the match day coordinators, doping control officers and staff, the anti-corruption staff, the ground staff, security, and etc. Apart from that, you will have to engage with the fans, the audience, and also with the parents of some of the players and staff. So before going to the field of cricket, I would like to give a glimpse how we categorize the injuries in sport medicine. We usually categorize it as acute and overuse injuries. Overuse injuries are injuries which happen due to repetitive actions or movements which causing wear and tear of those structures. So these are usually a chronic injuries, but sometimes the onset can be acute. So these are one of the classification of acute and overuse injuries in field of sport medicine. So when we talk about the common injuries in the cricket, these are few of those in the list. For example, contusion, abrasion, lacerations, strains, sprains, tendinopathies, bone stress injuries, head injuries, concussion, injury to eye, ears, nose, fractures, dislocation, cramps, blisters and callus. As there would be some more sport medicine lectures in the future, I am not much going to touch the fractures and dislocation and injuries to eyes and ENT today, but I will go with others as a brief account, as an overview, what we do in the field of cricket, especially in field management. So first we will look at the common acute injuries we encountered in sport of cricket. So there is a way we manage in field or in the ground these injuries. So there are some common regimes we used to do. So these are two of some famous regimes, what we call Prince regime and police regime. So basically they are more likely the same with minor changes in between. So in Prince regime, we have to protect the player from further harm, rest, put the ice or cryotherapy as we say, and NSAIDs. Actually that means analgesics, compression, elevation and appropriate referral when in need. In police regime, it is more or less the same, but there is a special word called optimal loading. Unlike in the previous regimen, the optimal loading is better than having a complete rest, which we also say active rest. That means if the player can weight bear without any pain, it doesn't have to be weight bear or the movements. If he can do without any pain, you should allow him to have some gentle range of motion or even weight bear, because it has a favorable outcome in the rehabilitation. So first we look at the contusion. This is one of the commonest injuries in the sport of cricket. This is a type of direct injury, and usually the area of injury are skin with subcutaneous tissue, muscles, bone and rarely organs in the cricket. So the management usually what we call the magic spray, that is a spray with analgesic and coolant component, putting some ice, and you can add some protective equipment above the covering the injured area, so the player can be allowed to play. Usually with contusion you can actually allow to play except for some severe contusion, for example a large intramuscular hematoma causing a contusion causing a large intramuscular hematoma. And also another common injuries are abrasion, laceration, that not that much common in the field of cricket, but it can happen especially around facial area. So the management include the cleaning and proper dressing, and with the laceration may need closing. So suturing, clipping and some adhesive tape can be used, but not all. You have to understand when the players are in act, where they are doing their sport, they get sweat a lot. So some adhesive tapes won't be sticking and closing the lacerations. So if you are using some adhesive tapes, you have to understand that those you have to use some special adhesive tape which can close even with the sweaty skin, and you can use ice which will reduce the bleeding in the lacerations, and if needed you can also use analgesics and local anesthetics. Apart from that, for dressing we use some hydropolymer resin, silicone resin, also matrix resin, and we have to think with regard to the lacerations, especially whether that players need tetanus toxoid injection in future. So next I want to talk about the ligament sprain. So the most common ligament sprain we see in the sport of cricket are ankle sprain, sprains in the knee joint like ACL sprain and meniscal sprain, and sprains in the finger. Today I am only going to touch about the bit of an overview about the ankle sprain. The other sprain will be covered in our subsequent lecture series. So ankle sprain is one of the most common sprains you see in many sports, and it can be categorized into high ankle sprain and low ankle sprain. High ankle sprain occur in between tibia and fibula, and low ankle sprain in between either tibia or fibula with the bones in the foot, the ligaments running in between there. So when we talk about the low ankle sprain, that is the most commonest form than the high ankle sprain, and it can be divided into medial and lateral ankle sprain, and the lateral being the most common ankle sprain we see in the sport. So when we talk about the lateral ankle sprain, we have to know what are the stabilizing ligaments in the lateral ankle. So what we call the ATFL, or the anterior talofibular ligament, CFL, the calcaneofibular ligament, and PTFL, the posterior talofibular ligaments, are the static stabilizers or the ligaments in the lateral ankle, and sprain can occur in one ligament or more than one ligament. And the usual mechanism of injury of a lateral ankle sprain is a inversion type of injury. So usually the player is present with pain and swelling in the area after an inversion of the foot, and he may not be able to weight bear and may be limping. So what we do in the field is, it depends on the patient condition. For example, the patient can't weight bear, it's better to take that player out. And other management include the analgesic, putting the ice in the area, and taping and brace. And the problem with the ankle sprain is, there's a high recurrence rate, especially in the first year after the injury. And also recurrent ankle sprain can be lead to instability, and also one of the main problem for the players is the performance drop, because recurrent ankle sprain can cause instability, and they might try to go to the field prematurely and have pain and again come back to the field of rehabilitation. So those things can be lead to performance drop. The one thing I have to say is, whether it's a mild or severe ankle sprain, you have to have proper rehabilitation, because even with minor ankle sprain, the recurrence chance is higher. So you have to avoid that with a comprehensive rehabilitation program, and it's better to complete the rehabilitation program before you send the player to the competitions. And next thing I want to discuss is muscle strains. The common strains you see in the cricket are hamstring strain, side strain, and rotator cuff strain. Today I am going to only look at the hamstring strains and side strains. The hamstring strain, one of the common muscle strains over many sports, not only in the cricket. We can broadly divide hamstring strains into type 1 and type 2 hamstring strain. So type 1 hamstring strain is the most common hamstring strain. It occurs during high speed running and commonly involves the bicep femoris muscle. When we talk about the type 2 hamstring strain, this is due to the excessive lengthening of the muscles, and usually it can occur with either high speed or in the low speed. So it can be either low velocity injury or high velocity injury. And the commonly involved muscle is semimembranosus muscle. And compared to type 1 hamstring strain, this is usually less dramatic in the acute phase. But the problem is, when we talk about the rehabilitation, the type 2 hamstring strains take more time to rehabilitate. So when we talk about the hamstring strain, in cricket, the most common one is the type 1 hamstring strain. So I'm going to more focus on that. So usually when the hamstring strain occur, the player and even the people who looking at him know he got a hamstring strain, because the usual presentation is, during some running, he suddenly stop and catch his posterior thigh, because there's a sudden pain and it will usually stop the activity then and there. And sometimes you may hear the pop sound and there's acute declination of the function. For example, he may not be able to run and walk thereafter. And there may be ecchymosis in the posterior thigh and tenderness in the area with the examination. There might be palpable mass especially after a tear, causing the contractility of the separated muscles, limping or stiff leg gait. For example, people with the hamstring strain they don't like to bend their knees and move their hips because it will increase their pain. So there's something called the stiff leg gait. Usually with the hamstring strain, people tend to have this gait. And also there will be pain with active and resistant knee flexion and hip extension, and also pain with passive knee extension and hip flexion. So the on-field management is usually analgesic, ice compression, elevation, and avoid further harm. That means usually after hamstring strain, you should better to take the player out from the game because it can cause further harm. And as you see in this picture, this is not something you should do in a hamstring strain. The stretching in the acute phase can lead to more harm. Yes, there is a place in gentle stretching in the rehabilitation program after the acute phase when there is no pain with the movement. So you shouldn't do any stretching in the muscle that has underwent a strain. It doesn't have to be a hamstring strain. Any strain, you better avoid stretching in the acute phase. When we talk about the problems, so the complications associated with the hamstring strain is, one thing is mostly for the players being out of the team for some time, and also there's a high risk of recurrence, and also most players underwent a hamstring strain have fear of recurrence. So to avoid these things, you should better to have a comprehensive rehabilitation program. And after a hamstring strain, if you are not properly rehabilitated, there's increased chance of injuries into ipsilateral or contralateral lower limb, lower back, along the kinetic chain. So even there can be even some chronic pains in the neck after a hamstring strain if you are not properly rehabilitated. So then we look at what we call side strain, one of the common strains you will see in the cricket. So this is usually occur in any sport which require highly repetitive, unilateral, asymmetrical, explosive action that place a great demand in the trunk. So this is actually strain in the external oblique muscle, and that muscle get tear at the level of cartilage, the ribs and the costal cartilages. So mostly commonly involve the 11th cartilage, 11th rib and the 11th costal cartilage. Apart from that, 10th and 9th ribs are also can be involved commonly. Apart from external oblique muscle involvement, internal oblique muscle involvement and transverse fascia tear can also seen in this injury. And in field of cricket, this is usually seen in the fast bowlers, and this injury usually occur contralateral side of your bowling arm, and usually the player will be presented with pain over the lateral aspect of the lower costal margin, and pain may be worse with the deep breaths, cough, palpation, even the stretching of the area. This is a clinical diagnosis, but at the high level, the elite level, usually people do MRI for this. The management involve pain management. You have to give adequate analgesic, rest from the activities, and also a proper rehabilitation program. There's a common misnomer with the side strain among the players that in the life of a fast bowler you will get at least one side strain, and after you get a one side strain, you won't get any thing in the future. But actually what the research show, especially there has been some research in the Australia, they have shown if there is a side strain in a fast bowler, this you can have 30% of the recurrence in the future and 20% recurrence in the first 12 months. So you have to understand the recurrence is actually common with the side strain, and you have to manage it properly. So this is an overview of the muscle strain. I have talked about the side strain and the hamstring strain. Then we'll move into head injuries and concussion. So we know there are several classifications in the head injuries, for example, open versus closed, primary versus secondary, and also focal, diffuse, hemorrhagic, non-hemorrhagic. But in the on-field management, as a match doctor, what we usually use is the severity scoring of brain injuries. For example, mild, moderate, severe. And also we know that mild, moderate, severe can be based on several factors. One thing is a GCS classification, the hospital stay, time of loss of consciousness, such as. But in the on-field management, we only focus on the GCS based grading. And we have to know that every medical personnel attending into a head injury, or even in a cricket match, even there has not been a head injury, the every medical person should have at least the knowledge of basic life support with how to handle the cervical spine. We all know there has been in the history many head injuries in the cricket, and actually the first fatality reported in the cricket is due to a head injury in 1624. But there has been not proper guidelines for many years and decades. But after the Phil Hughes injury, as you know, his death, there has been more concern over the head injuries and concussion, and now the ICC had put guidelines into the concussion and head injuries. So when we talk about the concussion, actually that has a broad definition. What you have to know is it is either occurred with a direct blow to the head, face, neck, or an impulsive force that transmitted into the head area. And usually this results in a rapid onset, short-lived symptoms which resolve spontaneously. And when you see these symptoms, you will see these are more towards the functional disturbances rather than a structural injury. And when you see the conventional imaging, you won't see any abnormality. And this is consists of greater set of clinical symptoms that may or may not involve loss of consciousness. So you can have a concussion even without loss of consciousness. And usually these clinical and cognitive symptoms will typically follow a sequential course of resolution. So there are many symptoms and signs in concussion, and some even may overlap with structural head injuries. So you have to look at these and recognize these. And this is actually a challenge when you are doing this evaluation on field. So when we think about the concussion, what we follow in cricket is the ICC guideline for the concussion. In on-field, the way the guideline suggests is the first contact should be team physician or team physio. If he need, he can call for the match doctor, and he have to go with the protocol that was provided with the ICC guideline. So there are some questions to ask and some tests to do. If he diagnose the concussion then and there, the player should be taken out. And even he have a suspicion of concussion, that the player is having a concussion, you should take that player out. If you are 100% sure this player is not having a concussion, that only you can allow this player to carry on. And you have to remember, every hourly or 2 hourly you have to assess that patient as a team physician or the physio. And even after a blow to the head and you see that there is no concussion symptoms and you are absolutely sure there is no concussion, you have to keep the eye on that patient for time duration, because as I mentioned in the definition, the concussion can have symptoms which occur after some period of time. So you have to keep an eye on that player. So after taking the player out, you have to properly evaluate. Usually this is where match doctor come, and he will have a proper evaluation, what is called with the SCAT-6 evaluation. What is the SCAT-6 means? The Sport Concussion Assessment Tool, and it is now in the version 6th version. So after proper evaluation, you have to document it, and usually you have to inform the match referees, because there are some things done in the cricket in the past few years to improve the health of the players, especially the players with concussion. So the strategies are, they have implemented concussion protocols and guideline. There is one called the concussion substitute. So after a player having a concussion, you can substitute another player to the game, and there is something called mandatory rehabilitation program. If a player is diagnosed with a concussion, there is a minimum period, but with the symptoms you can increase that period. Okay, so we have to know what are the advices we give into the concussed player. Not only the concussed players, the players around him, the family members and others in the team who engage with that player. So the first advice is to have a cognitive and physical rest. You can all understand what it meant by physical rest, so that players should not engage in any sport activities or even exercises, and he should not have any moderate to vigorous intensity activities. But the main thing we have to focus is another main thing is a cognitive rest. So if he is a school going child or one who is doing a higher education, they should be advised in this period of cognitive rest, don't study, write and read. They should have a proper cognitive rest, and also they should be advised to refrain from screen. That means don't watch TV, computer screens and even the phone screens. So this cognitive and physical absolute cognitive rest period depend on the sport. In cricket, it has been suggested to 24 to 48 hours. If the patient is having symptoms in even after this period, you can prolong this period. So in ideally, major symptoms should be resolved by this time. So this is the flow chart that was given by the ICC guideline. As I mentioned previously, if you are suspect of concussion, you should take out that player, and if you have some clear diagnosis of a concussion, also you should take out the player. And you should have remember, when you think about the concussion, let's say the ball has been hit on the head, you should go into the field with the view of management with ATLS protocol. You have to first rule out the structural injuries to the head. If you are suspecting structural injuries, which we call the red flag signs, you should immediately take out the player and refer to the closest health institute. Apart from that, there is no structural injuries, but you are sure of the diagnosis of concussion, you should again put the player into the side of the field. And there is absolute no concussion symptoms and signs. The player only can then be allowed to play, but you have to have a continuous monitoring of that patient. So the next topic is going to be the overuse injuries you see in the cricket. So these are usually chronic injuries. So most of the time you don't have to acutely intervene during a match. What you have to intervene is during the off period. You should have a proper rehabilitation in these overuse injuries. Sometimes, yes, with important matches, you can allow that players to engage in sport, but you have to keep in mind that there is a risk of further injury. So one of the most common tendinopathies we see in the cricket are rotator cuff tendinopathies and mid-portion Achilles tendinopathy. So first we look at the rotator cuff tendinopathies. We know the shoulder joint is a ball and socket joint with a smaller socket. So there is a higher range of mobility with sacrification of the stability. When we talk about the stabilizing factors, we can divide them into static and dynamic stabilizers. Static being the joint capsule, labrum and some glenohumeral ligaments. And when we talk about the dynamic stabilizers, the main dynamic stabilizers are rotator cuff muscles. As we know, supraspinatus, infraspinatus and teres minor to the posterior side of the scapula, and subscapularis in front of the scapula. So in field of many sport, due to overuse, repetitive action, especially the overhead repetitive action, there is a tendency to have rotator cuff tendinopathies. In cricket, this is usually mostly commonly seen among the bowlers, fast bowlers as well as the spin bowlers. So the presentation is usually insidious onset of pain, but sometimes you can have acute pain in a teared rotator cuff. So we see that pain usually occur with certain movements. This pattern actually governed by the injured muscle. The most common muscles, as we know, the supraspinatus and also sometimes the infraspinatus. Usually in these tendinopathies, the supra and infraspinatus, we see that pain occur with the overhead movements. And also with this condition, sleep on the ipsilateral shoulder may be painful, and in the examination you see that there is a tenderness or the greater tuberosity in the supraspinatus and intraspinatus muscle involvement. And pain can be radiate into lateral upper arm, also can be into the neck. So sometimes doctors, especially doctors who are not much exposed to the sport aspect, sometimes may think this pain occur due to cervical injuries, cervical radiculopathies, because Sometimes players say there's a neck injury and pain is radiating to the lateral upper arm. But you have to know, you have to especially ask from that player where you get the origination of the pain. So usually in this condition, the first place you get the pain is the lateral aspect of the shoulder, especially the deltoid region. And this can be also associated with what we call the impingement features, symptoms of associated bursitis, and degenerative changes like calcific tendinopathies or the tear of the muscle. So when we talk about the muscle tears, for example supraspinatus muscle tear, it will be associated with rest pain, night pain, and there's a considerable weakness and loss of active range of the motion of that muscle. And there are some special tests we do, and those can be positive. For example, drop arm test and external rotation leg sign. When we talk about the management, rehabilitation is the main management. The physical therapy of the rehabilitation is the main aspect of the management in the rotator cuff tendinopathies. You have to see what are the factors that cause this disease or the entity, and you have to safeguard that patient from further harming by avoiding doing these precipitating factors or correcting them. We have to advise relative rest, avoiding from precipitating activities, and you can apply ice locally. There are some other physiotherapy modalities, for example ultrasound, laser, ESWT, that means extracorporeal shock wave therapy, you can give to the patient. And also analgesic and muscle relaxants can be used. But the thing is, we have to understand there are no level 2 evidence for use of NSH, also ultrasound therapy, laser, magnetic therapy and inferential therapies yet. And also we use taping. And apart from that, you have to understand there has been a trend in the past to give corticosteroid injection. Yes, it actually resolves the symptoms temporarily in the short term, but when you think about the long term, there can be many problems. For example, it will reduce the muscle strength and increase the risk of tear, especially with the repetitive injections. And sometimes we may have to go underwent with the surgical options. Example, with significant muscle tears and sometimes the calcific tendinopathies as a last option. Then we will look at the mid-portion Achilles tendinopathy, which is another common injury you see in this cricket and also in many sports involving high speed, sudden powerful movements. So this is usually associated with the recent change in tendon loading. For example, if you increase the training load volume suddenly without going in a gradual manner, there's a chance you can have the mid-portion Achilles tendinopathy. And also sometimes you see the changes of footwear or the ground you practice, there's a tendency you can get this injury. Mostly seen among the cricket fast bowlers. Apart from that, when you are doing some plyometric training in cricket in any player, sometimes this injury can get. So this is associated with the insidious onset pain around the mid portion of the Achilles, and what you see is this is usually occur with the weight bearing plantar flex movement. But when the condition gets severe, even without weight bearing plantar flex movement, you can get the pain. Some may have experienced morning stiffness, swelling and warmth, and in examination there may be local tenderness and thickening of the tendon and pain with the resisted plantar flexion and pain with the passive dorsiflexion of the ankle joint. So as I mentioned previously, the tendinopathies are mainly managed with the physical therapy, the rehabilitation program. You can use analgesic, taping, bracing and injection therapies like sclerosing injection, high volume image guided injection and PRP injection, electrotherapy, for example ESWT, and as I mentioned previously, it's better not to give a corticosteroid injection to a tendon. As a last option, sometimes we have to go underwent with the surgical management. Next topic is going to be another overuse injury, what we call the epicondylitis, which occur around the elbow joint, commonly divided into medial epicondylitis and lateral epicondylitis. In cricket, the medial epicondylitis usually referred as the thrower's elbow. This is mainly due to repetitive bowling or throwing motion. So usually you see this disease entity in the bowlers or sometimes with the fielders. So there will be a pain in the medial side of the elbow joint, which is with insidious onset and worsening with throwing, wrist flexion, pronation of the forearm. Management is mainly physical therapy and correction of predisposing factors. Lateral epicondylitis usually commonly seen in batsmen in the field of cricket, usually associated with insidious onset lateral elbow pain, which may worsen with the wrist extension, elbow supination, finger extension and elbow extension. As I previously mentioned, the management is mainly a physical therapy with correction of predisposing factors. And you see this injury, the lateral epicondylitis in batters due to incorrect technique or sometimes with the heavy bat. So you may have to correct them. The other therapies that we can use in the epicondylitis are some bracing, nitrous oxide therapy, acupuncture, manual therapy, and some electrotherapeutic modalities like ESWT, PRP, autologous blood transfusion, botulinum toxic injection, and sometimes you may need surgeries. But you have to understand the highest evidence of management is with the physical therapy. So we go to other therapies when they are failing or sometimes as adjunct to the physical therapy. Low back pain is common among cricketers as in many other sports. Usually when we are classify the low back pain in area of sport, we usually divide them into specific and non-specific low back pain, and we can also subdivide the specific low back pain into serious condition and not so serious condition. So the serious condition, or what we call the red flag condition, include malignancies, infection, fractures, inflammatory conditions like axial spondyloarthropathies, and conditions that give cauda equina symptoms or the cauda equina syndrome. So if there is a serious condition, we have to refer them into appropriate place. For example, the player is having axial spondyloarthropathy, you have to refer them into rheumatologist, and a fracture, you may have to refer them into orthopedic surgeon. But when you talk about the non-serious conditions like muscle-related lumbar spondylolysis and disc-related and many other things like modic changes, you can mostly manage them within your team. So when you talk about the serious condition, you have to appropriately refer them into the relevant field. When we talk about the specific low back pain with non-serious condition, what we commonly see in the cricket is muscle-related problems. For example, strains, chronic strains, spasms, sometimes muscle soreness, cramps, like that. Apart from that, there's a special entity called lumbar spondylolysis, which is actually uncommon in cricket, but when we think as a disease entity, we commonly seen among cricketers and gymnastics. And another one we commonly get is a disc-related pathology. And also players can get non-specific low back pain. That means you cannot actually diagnose a structural point for this disease. This is usually associated with several risk factors such as physical, lifestyle, neurophysiological, psychological and individual factors. So you have to address them to actually manage these conditions, because there is no actual structural point that give this non-specific low back pain. So we will see the spondylolysis. I'm not going to look much on muscle related and disc related in this lecture. So spondylolysis, as I told before, it is a commonly seen in sport which involve extension activities. For example, in cricket, the fast bowlers, and also you can commonly seen among the gymnasts. Though as a disease entity, this is commonly seen among cricketers and gymnasts. When you talk about the cricket players, this is actually an uncommon injury. Spondylolysis is actually what we call in definition stress fracture in pars interarticularis. The pars interarticularis is the area in between superior and inferior facet, but recent studies suggest the area of involvement actually mostly not in the pars interarticularis. Actually now what we commonly see in between pedicle and the lamina. So the most commonly involved vertebrae is the fifth lumbar vertebrae. When we talk about the clinical features, many will have asymptomatic throughout their life, even they have this stress fracture. When players or the patients get symptomatic, usually it is associated with lower back pain, which get with the hyperextension of the back, sometimes with the lateral flexion and retraction, and commonly associated with buttock pain and hamstring tightness and pain, and occasionally can present with radicular pain along the L5 nerve root if there is a nerve impingement occur. Rarely you get cauda equina symptoms. Usually this is happen with spondylolisthesis due to bilateral stress fractures in the same vertebra. What we call the spondylolisthesis is relative movement in between the vertical two vertebra because there is a disconnection in between them. So in spondylolysis, you have to have bilateral spondylolysis to get the spondylolisthesis. In examination, this is one problem we have to face because most are asymptomatics, and even with the patient who having symptoms, sometimes they may not have any signs with the examination. So some may have local tenderness, some may have positivity for special tests like stroke standing test, but you have to understand all the tests involved in the spondylolysis have low specificity. So when we talk about the investigation, the basic investigation you have to undertake is the X-ray within view of you see the fracture. So AP view, lateral view, and you have to specifically order oblique views. In oblique view, there's a special sign called collared Scotty dog appearance. So you will see the pedicles, lamina, and that area. You can see a Scotty dog, and when there's a fracture, you see that Scotty dog has a collar. So that is why we call it collared Scotty dog sign. And also you can do bone scan and MRI scan, but the gold standard for seeing the spondylolysis is the CT scan. The management include, if the patient is symptomatic, the pain management, patient education, rehabilitation, activity restriction. Sometimes you may need a brace, and also sometimes you may need operative involvement. And you have to understand sometimes this fracture is associated with non-union and can heal with a fibrous band. You don't have to worry about that because even it heal with fibrous band, if it is asymptomatic, the player can come into his previous performance without any problem with a proper rehabilitation. So this is the main area of injuries we seen in the area of field of cricket. So as the today lecture is to give you some idea about the sport medicine in cricket, there are some minor topics involved with any sport. So in field of cricket, one thing is, as we know now, the women's cricket is gaining more popularity. With the female gender, there are some associated with some special problems. For example, when we see the disease pattern, there might be some changes compared to male counterpart. But one thing I have to focus is the pregnancy and the cricket. So actually there is no specific ICC guideline yet, but some cricket board have given local guidelines. This is a guideline I took from the England Cricket Board, and they have advised to avoid practicing and engaging cricket any women player who is having a pregnancy, because they have mentioned that there is increased risk to the pregnancy and mother, because this is a in a way contact sport, because the ball can hit on your stomach. The risk is more after the first trimester, but even in the first trimester there is some degree of risk. And after pregnancy you have to go ahead with the local guideline. As I take this in with the England Cricket Board, there's a mandatory period you should avoid. In England it is 2 weeks. In the first 2 weeks after the delivery, you cannot involve in any job, and after that you have to take a holistic approach, depend on the player, the mother's condition, whether she is willing, whether she is not having any complication, and other factors like whether the team is willing to take her to the sport in the early phase of the motherhood. So this is a holistic approach you have to discuss among. And another thing you have to know is when a player get to know she is pregnant, they have to inform immediately to the regarding cricket team and the management. As in this guideline, they have mentioned that you should avoid playing cricket if you are pregnant, but sometimes the player want to play and engage in the sport. Then they have mentioned, especially in this guideline, very specifically, that player should take all the responsibility of risk. So that is one thing you have to understand. So you can't forcefully say to a player, don't engage. You can give the advice. If she is going to continue to play with the pregnancy, she has to bear the consequences. The players should know their responsibilities also. So apart from musculoskeletal injuries, there's another common injuries you can get with the environment. So one thing is heat-related injuries. For example, countries like us have hot and humid environment. So if you are not adequately adapted to the condition, you can get heat-related injuries like heat exhaustion and heat stroke. Also, in a rainy condition, there's a chance of lightning strike, because this is play in open area. Sometimes the pollution in the environment, for example, our cricket team has exposure to one of these environmental related injuries in India back in time with the smoke, which caused some of the players to have breathing difficulties, and also some insect attack, bees, wasps, and also some injuries can occur to players and audience with the degraded structures in the stadium. So when you are a sport physician or a match doctor, apart from the musculoskeletal injuries, you may have to treat some minor ailments like headache, cough and cold, vomiting, diarrhea. Apart from that, some other medical conditions and sometimes serious condition among players, management staff, the supportive staff, sometimes in the audience also. For example, cardiac arrest, strokes, allergies such as. So you have to have a basic understanding and knowledge how to manage them. So this is the usually medical related conditions you have to engage as a sport physician, match day doctor or team physician. Okay, then we will look at what are the basic knowledge and skills of a sport physician. So basically any sport physician should have thorough understanding about the musculoskeletal injuries and how to manage them at the field. Apart from that, He or she should know the management of serious medical condition and general knowledge about the common ailment. And one thing as a sport physician should know is when to engage. For example, in different sport have different rules to engage as a doctor. For example, in cricket, you cricket as a match doctor, not the team physician, as a match doctor, you can go into the field during a match in certain circumstances. For example, if the umpires ask you to. Another one is usually when there's an injury, usually the first contact should be the team physician or the team physiotherapist, and if he asks you to come, you should go there. And also any injury happen to umpires, then you should go to the field. And apart from that, any non-musculoskeletal condition causing a collapse, so sudden collapse even without any contact injury, you have to go then and there. And let's say that two players have collided with each other and lying on the ground without moving or with minor movements. So then you have to go there because team physician or team physician can manage only one player, so you have to go and look after the other player. So those are the common rules that you can go into the ground during a play. And if there are some special rules, you have to know in beforehand with the medical coordinator of that match. Are there any special circumstances you can engage when there something happen? So apart from that, you have to know some knowledge in doping and anti-doping, because you are going to prescribe some medicine. So some medicine may under the category of doping. For example, during in play, you cannot give tramadol as a painkiller. It is in the prohibited list in World Anti-Doping Agency. So you can get into some trouble. So any medical person should have at least basic life support skill. As a sport physician, you should have, preferably you should have ALS and ATLS knowledge. You should be able to pre-plan the things, because you have to make quick and accurate decision in the play, because many people watching you, not only the players and the team, the audience, sometimes through the media, the whole world. So you have to do quick decision and do it accurately, because later there may be some consequences you have done it improperly. And you should have communicating skill and leadership skills and many others. When you talk about sportsman, the athlete, there are some special thing you have to encounter. For example, difficulties you will have to encounter. One thing is emotional players. For example, during a competition, when you say a player to get out of the field because of an injury, sometimes that player can get emotional. Especially it is hard to manage an angry player, because definitely they are going to have physically more stronger than you, and inside the field there may be no people to protect you. So that's something you have to understand, and you should have good communicating skills and empathy and know the situation, how to handle these players. One of the common problem we see in any sport, it doesn't have to be in cricket, is a delayed presentation. So because players think this might be a minor injury, or this injury can cause them to get out of the team, they usually try to hide the symptoms and signs. So sometimes they present to us with when the condition get more worse. So that is one problem we see among the athlete population, especially in Sri Lanka. And another thing for the delayed presentation is, which I want to emphasize in here, is as a Western medical practitioner, we have not met their need in the past. So what is we have been commonly prescribed those players with the injuries are analgesic and some period of rest. The problem is this is their livelihood, this is their income. So they want to know how long you have to rest, what are the things you can to do improve the get into the fitness. But the thing is, as most Western medical practitioners in Sri Lanka, they don't know how to advise them, because that's a common thing, because in our basic medical degree we don't learn how to handle these things. So one of the key aim in this today's lecture is to have a basic idea, and in the future with our sport medicine series we will get a basic understanding how you can manage a player in a good way, so they will have a good impression in Western medical practice. So in Sri Lanka especially, there has been like a tradition from coach to coach, the player to player, they have gone into other medical specialties. We are changing that trend, but we need all the help from all of the you guys. So another problem we are encountering is the poor compliance, because when there is an injury, and some injuries need a prolonged rehabilitation program to properly get them into the play, but players, they want to go to the field quick as possible, so they may be not properly compliance with the treatment, and they try to go into the field once they don't feel any pain with the movements. But the problem is you have to properly educate them and say the risk is more, and when the next time you get the injuries, the severity can be get higher. So it is your responsibility to have a good communication and the education the player to have a good compliance with the treatment strategy. In hospital, when there's a rehabilitation to other, not about the other patients, I'm talking about, not the athletic population, you see the most common problem we are having is the poor compliance. So for example, in a physiotherapist, they give a physical exercises to do at the home. In next visit, they have in a month, usually what you see is those patients have done those physical exercises maybe once a week or twice a week, something like that, or sometimes they haven't done any. But in sport population, we see totally different picture sometimes. For example, there are over enthusiastic patients. For example, we advise them to do some exercises, the physical therapist, twice a day or 3 times a day. They try to do hourly or 2 hourly, by thinking doing more can let them make them heal rapidly. But you have to know actually it can worse the situation. So this is another problem with the athletic population, so you should have a better communication and patient education in this situation also. Another thing, as I mentioned previously, you have to understand the doping rules. And another problem we are facing as sport physicians are pressure from the other players, the player, the coaching staff, management, match officials, the relative, attendance, fans, media, so and other influential people. So you have to have a good leadership skill and communication skills to handle this. And another thing, though you not seen much in this country, litigations. Litigation is bit higher in the field of sport medicine. So then I will move into some minor topics with the sport, especially with regard to cricket. So one thing is doping. There is a organization called World Anti-Doping Agency. This is the organization which overlook the doping and anti-doping activities. They usually provide something called anti-doping code. So when we translate doping into Sinhala, what we call is Tahanam Uttejaka Bhavitaya. but actually it is not limited to taking prohibited drugs only. We call that act of doping is as a violation mentioned in the World Anti-Doping Code. So you have to have a basic understand about the World Anti-Doping Code, and usually the World Anti-Doping Agency, they publish a prohibited list annually, which is usually will activated from 1st of January to 31st December in that year, and this list is published 3-4 months prior to that year. So as a sport physician, you should update it with this prohibited list, so you can have a basic understanding what to give and what not to give to your athletes. I want to tell something for the all of you. You don't have to become a sport physician. Just go ahead in the internet and just type World Anti-Doping Agency prohibited list and download it. There's a list of drugs you can't give into the athletic population. Some drugs you can give in the out of competition period, but there are some drugs you shouldn't give to any athlete during their athletic career. And if you have to give them, there are some special things you have to done. For example, you have to get a permission through what we call the therapeutic use of exemption, TUE. You have to submit, the athlete have to submit that into the World Anti-Doping Agency, and that World Anti-Doping Agency should accept that that this player actually need this medicine. So after that onwards, you can give that medicine to the athlete or the player. So another thing you see in most of the sport, organizing sport, is the anti-corruption. So there's in ICC there's an anti-corruption unit, and also in major cricket playing nations they also have their local branches. They are mainly provided in guidance and awareness regarding the corruption and anti-corruption, and monitoring to take action for especially the betting on cricket, misuse of inside information and match fixing. When we think as sport doctors, sometimes we have to meet these people. For example, let's say you diagnose a player with a concussion and you have to take that player out. So when you take that player out and you properly evaluate him and diagnose that this player is having a concussion, people from the anti-corruption unit that overhead in that match will come to you and ask from you, are you sure about the diagnosis and stuff? Because there's a law called that concussion substitute. Sometimes you can use this as a match fixing. So these people will definitely come if there's a concussion substitute, if you warranted a concussion substitute in the match. So this is another area you have to understand when you are a sport physician or a match doctor. So my last topic would be the biomechanics, which is another popular field in the sport of cricket with the advancement of the technology. So we have several uses of biomechanics in the area of sport. We are using mostly to improve the athlete performance and skills. Apart from that, we are using the biomechanics to resolve some legal issues. For example, in our country, Murali has some legal issues with his bowling action, and biomechanics used to resolve that conflict. Apart from that, we are used these two for the rehabilitations and the injury prevention. So you can have some biomechanical analysis of the injured players or sometimes the healthy players to understand what are the anatomical and functional changes in that player that can lead or predispose to further injury or future injuries. So with this biomechanical analysis, you can try to correct them. So this a technical field and gaining more popularity with time. Especially in developed countries, these are used in almost all the elite athletes. So this is the uh, all the topics for the today coverage. I hope you have learned something and you will do some betterment in this field. As any doctor, it doesn't matter, you don't have to be a sport physician, as a general practitioner, as a doctor in your hospital. I hope this will help you to resolve the musculoskeletal injuries not only in the sportsman, any patients that come in look to see for your care. Thank you very much.
Thank you very much, Dr. Patum, that is acting consultant in sports and exercise medicine, for that informative lecture. And we have received numerous questions via the registration forms and the chat box as well. And we'll address as many questions as time allows during the session. And there are some commonly asked questions, and I have selected some. Hope Dr. Patum can hear me.
Yeah.
Okay. Are pregabalin, gabapentin also prohibited under doping regulations?
Well, first of all, before starting answering the question, I want to thank this field, first of all, for giving me the opportunity. And the second thing is, we done this as a pre-recorded event because I have some commitment to do. So there might be some bless in the recording you. do. I hope you bear with us regarding that. So let me take into a question. So actually, you can safely give antidepressant and anticonvulsant. Still, it's not prohibited under the World Anti-Doping Agency. The usually prohibited tramadol, morphine, pethidine. Usually, they are not going to be in the in-competition period. So, example, if you are treating a patient who has a match that's going to be few days ahead, better not to do uh, pain killers like maybe. Other than that, you can safely do Panadol, Sunday, Panadol combination, NSAIDs, and also antidepressant and anti-anticonvulsant agent that can be sometimes as a analgesic illness. And another thing you need to know is sometimes some people give steroid to relieve the pain. Actually, that is not actually advised, especially in competition period. And if the competition is really near, uh, better to avoid steroid injections. So,
Okay, we have received another common questions. Is it necessary to screen all students who are willing to participate sports events, especially cricket? And is it necessary to examine by a sport physician? And how to assess the fitness of a player before the match? And are there any special examinations and investigations?
but it's like this. According to what minister provide, there are only three uh, actually two categories. You can screen the players, school or any other players. And one are people who have the diploma or degree in the sport medicine, and others are there's a training program that usually held by the ministry. So if you have the certificate for that pre-participation examination, you can also screen those children. Uh, the thing is actually there are uh, some fail with us, and also it is also available in the internet in the Ministry of Education as well as Ministry of Health website. You can download it. That is the question that has to be filled by the kid and if the kid is less than 16 years old, the guardian rules. And you have to do that easily. Put they are sending to your unit. Then you have to have some question and there are some
evaluation table. You have to do those examinations. To do. Ideally, every children should be examined because it doesn't matter sport is because of high intensity activity or low intensity activity. If there's some predisposition for cardiac uh, disease, there's a class with even with the mild intensity that the player can get some heart related or type related injury. Uh, so in our country, you have to go through with the history examination and you have to go to with an ECG. In ministry guideline, it said the ECG is must, every 9 years, and that is 1.5 kilometers in 1,500 meters and above. Then there are some impact so they have listed in the way. Impact is not actually that they are to take mandatory ECG. But it's better to take so you can safeguard yourself also. And when we think about the training evaluation, uh, there are some things we can do in our units, which is also mentioned in the Zoom application. Apart from that, mainly the training evaluation should be done by the trainer or the coach.
Okay, there's another question related to that same question. What are the heart diseases that are absolutely contraindicated to involve in sports for a school child?
Different have to be school time. Any person, especially there's a hypertrophic cardiomyopathy, arrhythmogenic hyperventricular cardiomyopathy. Uh, if you have Lugard disease, not just Lugard syndrome, the symptoms in ECG changes, the WPW syndrome. So there are several many others. These are the most common. Uh, and also sometimes we are not advised to do moderate, moderate, mild, moderate, and high intensity exercising. Marfan syndrome with circuit work in So those are the common things we are usually getting. The list is become too long one.
Okay, thank you. And there's another one. How can the serious muscle injuries initially be managed at primary care? And following an injury, what is the time window of keeping ice and warm compression and applying local analgesics?
When we think about acute stress, what we define is it has a mostly for the muscle injuries, first 72 hours. So, what you should do in the initial period, as I mentioned, you can do the initial this element. So, you can protect it from further harm, asking them not to engage in any demanding physical activities. You can keep quiet. Uh, you can essentially engage it. And you can, if there's a gain, you can eliminate the gain. So, you will be reduce the swelling, and even the hematoma. Now, when talking about putting in the ice, there are two circumstances. For example, if the player in a contention, during contention, if he is allowed to control the country, uh, you can apply analgesic spray for jail, and also uh, you can keep this as far as what they allow needed so umpires because usually within few seconds or few minutes they are going to restart the competition for the match. But then after the match, it is advised to keep race over the injured day about 4 to 5 times per day, sometimes 6 times a day. Uh, the duration you should keep the ICs something around 15 to 20 minutes. And you shouldn't massage with the wrist. You just keep it there. The other thing is you have to know is there are two ways you can have ice cream. One is a commercial available foods, and the other one must be made from skills with a quality ingredient. So most of the commercial available ice cream you can safely keep on the over skin, but especially when you made a formulated one, especially the quality ingredient, it's better to keep it thin above the skin you put the ice cream because as for the advice, we tend to keep it 15 to 20 minutes. So sometimes in the frequency is anything of like 4 to 6 times per day in just 22 hours. So sometimes the skin can be very ice. So that's why you have to keep in mind, you have to put the thin coats over the skin.
Okay, this will be the last question, and it is what is the pathway of sports medicine and the importance of subspecialization in sports medicine in this developing era? And somebody have asked how to establish sports medicine unit.
Okay. The thing is like this, the current path in Sri Lanka is you should first go ahead the postgraduate sport medicine diploma, which is part-time diploma with a duration of 1 year. Uh, During it, if with the sport diploma, you are qualified to sit for the MD exam. So that is the path to it. Uh, and usually with the diploma, with the MD, you can ask from the your hospital administration to start the sport medicine unit then. So usually without the qualified people, they usually don't know to start now. So that's the pathway for the PGA side. And also, if you are developing a sport medical unit.
Okay, now there were numerous questions they have asked, but according to the time constraints, I have to limit the questions. And thank you very much, Dr. Patum Hera, for your informative presentation on the sport medicine perspective in cricket.
Thank you,
And
Dr. Fatah, and thank
and
you,
we had
Sri.
more than 400 doctors in today's session, and your expertise has definitely provided all of us with a good understanding of this evolving field. And your dedication to sharing your knowledge with us is greatly appreciated. And to all our participants, thank you for joining today's free program. As mentioned earlier, the link for feedback and post-assessment questions is now available in the chat box. Kindly take a few minutes to provide your feedback and complete the post-assessment to receive your e-certificate within coming week. And the Shri program will continue next Sunday as well with another relevant clinical topic. We warmly invite you to join us once again for another productive session. Thank you, Dr. Patum, for your time and for sharing your expertise. And thank you to all the doctors who participated today. We look forward to seeing you again next Sunday morning. Thank you and have a nice day.